So good afternoon. First of all, I would like to thank the organizers to invite us to the conference and for giving us the opportunity to talk about depression and anxiety in people suffering from TSC. Since my colleague and I indeed work both as general psychiatrists, we are familiar with the burden that depression and anxiety can provoke in the quality of life. The importance of clinical expertise in diagnosing psychiatric disorders in patients with TSC cannot be overemphasized. There is an inherent difficulty in recognizing and distinguishing psychiatric illness from other central nervous systems aspects of TSC. TSC is associated with a range of neuropsychiatric disorders referred to with the umbrella term TAND. And as Professor De Vries already mentioned this morning, around 90% of the individuals with TSC have some of these neuropsychiatric difficulties during their lifetime. Yet only a minor percentage ever receive assessment and treatment, and this treatment gap still exists, and psychiatric disorders are still underdiagnosed and potentially diagnosed late.
Here we will focus on depression and anxiety disorders. The TOSCA study confirmed the high prevalence of psychiatric disorders, with anxiety disorder in 9.7% of the TSC patients and depressive disorder in 6.1%. When we look at the behavioral level, these percentages are even higher, with anxiety in approximately 33% and depressed mood in about 90% of the patients. Rates of anxiety and depressive disorders are higher in adults than in children. And they also found a clear pattern of increased frequency across increasing age bands. There were no significant differences between the two genotypes for depression and anxiety disorders, but both depression and anxiety disorders showed higher absolute frequencies in association with TSC1. Little is known about the pathogenetic basis of TAND. It is unclear whether it is rooted in TSC-associated neurobiological alterations, whether they are secondary psychological phenomena, because patients have to cope with the burden of the disease. But a study in 2007 by Muzikiewicz showed that several patients showed an anxiety disorder that long predated their diagnosis of TSC, which means that the anxiety was not just secondary to the burden of the disease. Anxiety disorders can take several forms, including generalized anxiety disorder, panic disorder, PTSD, which is post-traumatic stress disorder, and specific phobias. Here I will talk about generalized anxiety disorder and panic disorder. So GAD is characterized by the presence of excessive anxiety and worry about a wide range of situations rather than one specific topic. And the worry can shift from one topic to another, and it's very challenging to control. So people with GAD, they feel anxious most days, most part of the day, and they often can't remember the time that they really felt relaxed. The anxiety can be accompanied by several other symptoms, such as sleeping problems, concentration problems, restlessness, and so on. This makes it hard for those people to carry out day-to-day activities. Panic disorders are characterized by panic attacks. These are intense feelings of fear without the presence of actual danger. This is also accompanied by a lot of physical symptoms such as sweating, trembling, hyperventilation, numbness, and so on. And people with the panic disorder also develop an anticipating anxiety. They are afraid of having another panic attack, which will make them avoid certain situations. The symptoms of a panic attack usually happen very suddenly. They peak within 10 minutes and then they subside. But some attacks may last longer, or some attacks may occur in succession, so that sometimes people are also feeling anxious a very big part of the day. Depression then can also take several forms, including major depressive disorder, adjustment disorder, bipolar depression, or dystemic disorder. Here I will only speak about major depressive disorder. And one of the predominant symptoms is depressed mood or anhedonia, which is loss of pleasure in almost all activities. On this slide you can see also a lot of other symptoms of depression, including changes in appetite, changes in sleep, feelings of worthlessness, feelings of guilt, suicidal thoughts, and so on. Many people with depression also have symptoms of anxiety and also often have various pains. Most of us experience feelings of stress or unhappiness during difficult times, but this improves after a short period of time rather than being a symptom of depression. But if the symptoms last for longer than 2 weeks, those symptoms we can speak about a depression. The symptoms of a depression can range from mild to severe, and this will have an impact on the choice of treatment, as my colleague will explain later on. In people with TSC, there are a lot of people with intellectual disability, and the diagnosis of psychiatric illness in people with intellectual disability is challenging because there are limitations in their verbal abilities makes it difficult, but also the atypical clinical presentation. So people with intellectual disability are less likely to complain about depressed mood or to express depressive ideas. So the diagnosis of depression has to be made mainly on an appearance of sadness, changes in appetite, changes in sleep, and especially changes in behavior. Cognitive symptoms such as feelings of worthlessness, concentration problems are less frequent because those patients don't talk a lot about it because the difficulties of self-report, as mentioned before. Challenging behaviors such as aggression, self-injury, impulsive behavior are often key atypical features, but nevertheless these symptoms can also have other causes, as we all heard earlier today. So observation of these changes in behavior by caregivers is very helpful in diagnosing psychiatric disorders because often clinicians must rely on the report of caregivers. In people with intellectual disability, we see that anxiety disorders are more frequent, especially at times of stress. And stress can occur when there are minor life events or when there are changes in the daily routine. So these are times or moments that we should be very watchful. It's also not uncommon that anxiety or mood disorders will lead to somatic symptoms, which then result in requests for medical rather than psychiatric attention. So here also we have to be alert not to overlook a psychiatric diagnosis.
So concerning treatment, no unique management for TAND exists, and there is little evidence of the effectiveness of any specific psychopharmacological or psychological treatment for anxiety and depression in TSC. So we must rely on the treatment principle used in people without TSC. In case of a mild depression and anxiety, lifestyle measurements like exercise, mindfulness, sleep hygienic measurements, relaxation therapy can be helpful. With watchful waiting, we can monitor then whether the symptoms improve or not. Also, psychotherapeutic support can be suggested. Here, cognitive behavior therapy and ACT, that is acceptance and commitment therapy, are documented being most effective in depression and anxiety. The treatment of mood and anxiety disorders among intellectual disabled people are the same as among people with normal intelligence, but in anxiety disorders, often reassurance and bringing adjustments in the environment of the patient, like installing more routine, make already a big difference. Also, counseling at an appropriate level of complexity can be helpful. For moderate to severe depression, a combination of psychotherapy and psychotropic drugs is recommended. Here we think that psychopharmacological approach has an important role to play in the treatment, but should always be incorporated into an overall program of management. If there is an indication to use psychotropic drugs, there is a particular responsibility for organizing effective ongoing monitoring, including regular physical examination. The latter is especially important for patients with severe communication impairment who cannot describe the effectiveness of the medication or the adverse effects. Observation of caregivers here can add a lot of useful information, of course. The antidepressants who are the typical first choice are SSRIs and SNRIs. They offer symptom reduction both in depression as in anxiety. With the tricyclic antidepressants, more caution is needed because they can increase the risk of cardiac rhythm disturbances by prolongation of the QTC time. SSRIs and SNRIs can provoke ventricular arrhythmias as well, but only when they are used in high doses or in overdose. Special attention should be given to the bidirectional interaction between depression, anxiety, and epilepsy. Having depression should increase, could increase the seizures frequencies, and having epilepsy is known to increase the risk of depression and anxiety. Depression has also been associated with higher rates of drug resistance in people with epilepsy. So when implementing antidepressants in people with epilepsy, we must take into account that the antidepressant can influence seizures, but mostly in ultra-high doses or overdose. So generally, we could say that the risk of seizures induced by antidepressant is rather low. And here again, the first line antidepressants in people with epilepsy are SSRIs and SNRIs. Tricyclic antidepressant and bupropion are not recommended because of they lower the seizure threshold, and they are therefore to be avoided. Anti-epileptic drugs can increase or decrease the metabolization of antidepressants by the impact of the P450 enzyme system. So adaptation of the dose of the antidepressant could be necessary during the treatment. Older anti-epileptic drugs sometimes produce sedation and cognitive blunting, and some of them have even a depressogenic characteristic, so which could mimic or mask psychiatric disorders. We have to take that in account. On the other hand, there are anti-epileptic drugs that have positive effects on mood as well. Think about lamotrigine, carbamazepine, valproate. All three have strong mood stabilizing properties and are used in bipolar disorders. And others like gabapentin have even anxiolytic characteristics. So treatment of both problems, epilepsy and depression, is sometimes complex, but can offer opportunities as well. A more invasive treatment used to control seizures is the nervus vagus stimulation. This is a treatment that is also employed in chronic and refractory depression. So it should not only reduce depressive symptoms, but can also improve cognition and memory on the psychiatric level then. Low-dose antipsychotics could be another tool to be employed in anxiety disorders and to treat also symptoms of depression like agitation and sleep disorders. Though they should not be routinely used, the NICE guidelines recommend that antipsychotics should not be offered for general anxiety disorder in primary care, and if they do, monitoring for metabolic syndrome is important and necessary at each visit. There's also a warning that antipsychotics can also give a QTC prolongation, and they can decrease the seizure threshold. Benzodiazepines should better be avoided in treatment of anxiety, given the risk of dependence and abuse. They may even paradoxically heighten agitation and impulsivity and disinhibition, especially in people with intellectual disabilities. So clinical trials with mTOR inhibitors are going on, but I have no knowledge of results. There is a study of Russo et al. Published in 2016 that showed that everolimus improved the cognitive function in mice, but increases the depressive and anxiety behavior. So his findings could suggest that patients should be carefully monitored for psychiatric and neurological symptoms in clinical situation where mTOR inhibitors are used. So thank you.